Good afternoon, everyone. I see we still have some attendees trickling in, but I'm going to go ahead and just get started with the beginning of our presentation. Thank you for joining our webinar series for 2022. Today we have Dr. Guy Hembroff presenting. I'm going to go ahead and skip this him slide. Thanks again for joining. This is your chapter's programs team. So I am Lindsay Weeks, the program chair, and then Megan Vanderstel and Sharon Kim are also on the programs committee for the Michigan HIMSS chapter. And we also want to thank our sponsors that support our educational opportunities. They always help us support these webinars, and we couldn't do this without them. So today we have Dr. Guy Hembroff. He's the Associate Professor in the College of Computing at Michigan Technological University. He's the founding director of the Health Informatics Graduate Program. He also has expertise in medical AI, cybersecurity, and application development. And he also serves as the director of the Institute of Computing and Cyber Systems Center for Cybersecurity and a member of the Center for Biocomputing and Digital Health. As impossible. So if you want, Guy, I'm going to go ahead and pass it off to you.
Okay, thank you very much. Yeah, let me just go ahead and get my slides. I don't know, can you guys see me right now? Probably not. Okay.
I see your video,
yes,
but I don't see.
Okay, so let me go ahead and share out my slides. And we can get started. All right.
I can see your screen now, Dr. Hembroff. Thank you.
Yep, I'm just trying to tighten that up a little bit. Okay. Great. Well, thank you, everyone. I'm really pleased to have this opportunity, especially with HIMSS. I think HIMSS is one of those organizations that's, you know, and I'm reading verbatim, that they're dedicated to improving healthcare quality, safety, cost effectiveness, and access to information technology, information systems. And I think you can just tell by that very short definition that it's very interdisciplinary. And I think this is what makes me so excited to be presenting for HIMSS and just the HIMSS organization on a state level with Michigan, and then of course at the national level. The things that I do are very interdisciplinary, and that's what, you know, this kind of health informatics and really the healthcare field really exhibits. And so truthfully, I am not a medical expert, right? My expertise is in data science, is in network engineering, cybersecurity, big data, computational science, and different types of application development. So I really enjoy trying to solve problems in healthcare. And much like, you know, if you have a nurse, a physician, IT personnel, or if you have a CEO, they're really trying to do the same thing, right? So if we can kind of agree that everyone has a passion in terms of improving healthcare and where we're going with this, you know, then we can kind of see the need for interdisciplinary collaboration and really the expertise. And I see this every day. So a lot of my colleagues that are in the medical sector, especially with the research that I do with hospitals in terms of, you know, different types of image analysis. So developing algorithms for taking bone mineral density out of just a common radiograph and being able to use that for an opportunistic screening, or being able to look at quality control for pre and post surgery. All of those things depend on the expertise that they have to be able to do what I do. And so when we look at this, and you'll hear a lot of different types of terms, like maybe even explainable AI. If you look at the definition of explainable AI, it's basically, in the medical side of it, it's to be able to give a different type of trust, comfort level, familiarity with physicians or other medical personnel in terms of using different types of models or algorithms. But truthfully, what I find is that I learn more from them, at least at a high level, in terms of what they're doing to be able to tune the parameters of my algorithms to be effective, to be efficient, to really endure patient safety. And so HIMSS kind of sets up this really cool dynamic in terms of doing that. And that's what I want to kind of focus on here, is that, you know, we can look at technology and the advancements of technology and many things in the healthcare field where it's going. And we can see that everyone's on smartphones, everybody's, you know, carrying around a smart watch. And there's a lot of dangers and issues with that, but there's also a lot of potential. And I think what I wanted to get across in terms of this discussion is to look at some of that potential with also being cognizant of some of the different types of dangers that we have, like security and privacy and other elements as well. But there's a lot of potential, and that's what I want to just share with you and some of the different types of things that we're working on, and to go from there. So as I go through this, there might be different types of terms that you might not be familiar with. I will try to explain as much as possible. I'm trying to do more of a high level point of view. In fact, I can probably turn off my camera since you probably can't see me as well. But as you're kind of going through this, if you have different types of questions, you know, make sure that you ask me. I'll also leave my contact information at the end. So I'd love to follow up with you. I'm very passionate about this type of research and to really improve healthcare in the expertise that I have in collaborating with others. So, so these are the types of things that I want to go over. Really, the potential of capturing the amount of data to improve disease surveillance. With COVID, we've had to do a lot of that lately, every one of us. Population health management, engagement to really get people excited about being able to take care of their own health and really improving those overall health outcomes. And so how do we use this technology that we have some examples of delivering this particular type of care that we can aggregate information to make better clinical decisions? And that kind of comes through with the longitudinal records that we want to be able to create. Different types of data science approaches and models, that's a lot of my background, to improve not only just, you know, different types of health outcomes, but also the patient education and clinical decision-making is, again, important with the engagement aspect of it. And then looking at all the things that we have to deal with on a daily basis. Me being in academia, I don't know the struggles as much as you guys do, but I know in terms of standardization legislation, different types of approaches that we have with interoperability and security, there's a lot of different types of barriers that we're dealing with. And what are some examples that we can go ahead and actually get through that? So yeah, sit back, relax. If you have questions, please feel free to go ahead and ask. And if there's something that I can clarify, I'd be more than happy to do that. What I wanted to start off with is just basically the population health management and what we've done in this realm. Some of the things that we've done, and you have to start looking at what kind of data do we have in terms of what kind of potential do we deal with. And I've shown this slide many times over in different types of presentations, but it really brings a lot of different types of emphasis on just where things are and where things are going. So if we look at all of digital data, think of all the digital data, all the people who are Instagram, Facebook, taking pictures of their food and sending it to people, grilling out or whatever they're doing, all of that data that's being collected, 30% of that is associated with the healthcare industry, right? That's a pretty big percentage. And if we look at just genomic data alone, if we look at different things like pathogen surveillance and things like that I'm going to talk briefly about, that is actually accounting for 20 to 40 exabytes, right, by 2025. And if you're not familiar with exabytes yet, it's basically equal to looking at about 1,000 petabytes, or, you know, it'd be essentially 1 billion gigabytes if you want to put it in those terms. So it's a lot of data that it has, right? And so where do we go ahead and pull this data from? How do we check the integrity of this data? Those are many things that we're struggling to deal with, but again, it gives us a lot of different types of potential. When we start looking at, you know, the Internet of Things, and we look at smart homes and Internet of Medical Things, really healthcare accounts for about 40% by 2025 is what it's currently projected at. Again, a very, very large percentage when you think of all the IoT devices that are out there, that 40% is associated with Internet of Medical Things. And then this number went from 7.43 in 2020 to now 9.42 million in 2021. And it's just going to continue to increase. But we look at security and privacy, and we look at the potential for hackers to be able to get this information, because health data itself gives, insurance information, gives financial information. It gives obviously the healthcare for different types of fraud that's done in that sector. But there's a lot of different types of potential that can be reached from just simply going ahead and looking at being able to get medical data. And so being able to come up with different ways that we can make this more ubiquitous, that we can go ahead and take, pulse and different types of measurements, but also to keep that information secure is a challenge. And that's something that we need collaboration in order to do this. And then of course, from the data science standpoint for the machine learning, all the other different types of artificial intelligence, again, to basically break it down as simple as being able to detect patterns, right? That's what we want to be able to do. We want to be able to detect these patterns, make different types of correlations or causations in terms of what kind of data that there is. And whether you're looking at images or you're looking at nursing notes, or you're looking at other elements from lab with loin codes, all of these things are basically just different types of features, like would be different types of ingredients in a recipe to be able to come up with this different type of answer for prediction, right? And we look at preventative health and those kind of things. This is very, very important. And so these are the types of things that we need to know is what is that value for population health management? The bottom line is we have a lot of different types of data opportunities, but how do we use that in a way that's going to be productive for the patient and ultimately for the healthcare industry? So we kind of looked at this pandemic, and a lot of people were doing a lot of different types of work in terms of research. We've talked with different groups in Michigan, Upper Great Lakes Family Health Center, the FQHC locally here, the Michigan Primary Care Association were also instrumental in terms of us being able to conduct this particular type of research. But what we found is that, a lot of people were doing work in terms of predictions, but really nobody was doing localized predictions, and especially with the peak. And so we started to see, different types of problems with looking at supply chain and basically struggling from when that peak of the COVID pandemic hit. And so that was our focus on this, is to see, how can we go ahead and look at localized prediction for COVID at different types of data sources, and then being able to enhance the supply chain based off of that. So this proof of concept and then led into different types of elements of implementation really was associated with many different types of data, right? You might or may not be familiar with some of these different points, but 1.3 acres provides a lot of different types of data that's aggregated from different types of data sources. And basically what we wanted to do is to say, by county, can we go ahead and look at being able to predict what the actual peak would be and when it's going to be coming, so that hospitals, clinics, different types of healthcare organizations could prepare for it. And we looked at different types of research that was being done. So if you looked at, the SEER model, and, this is just if you have susceptible, exposed, infective, and recovered. This is a common model that's used in epidemiology. GRU is just the gated recurrent units. This is basically just dealing with long short-term memory, and this is bidirectional. I'm just trying to go over these so you understand what these are. This is autoregressive integrated moving average. So basically what it comes down to is that these are all good models. They weren't good at predicting the peak. And so we needed to come up with something different, right? And that's what we really looked at in terms of doing this. And really what I'm going to explain is kind of what we did with this ANFIS model using particle swarm optimization. And what that does is that combination really provided the best results in terms of predicting what that peak would be, not 3 days, not 5 days, but actually 14 days ahead, to be able to give time to those hospitals to be able to react with their supply chain. So this particular type of ANFIS algorithm, which is adaptive network-based fuzzy inference, it's basically just an artificial neural network that's being utilized for this. And essentially what it can do is it can go ahead and help with these predictions on a rule-based type of method. And so if you look at this figure here, as you can see, it has, it's very choppy in terms of peaks and valleys, which make it kind of challenging to go ahead and actually do accurate predictions. So out of this 14-day kind of prediction, we used a 7-day moving average that would actually create this smoothing technique that allow us to get a more accurate base on the average of units, and then be able to use that in terms of being able to understand what kind of peak we're going to be expecting within that time. And so if we looked at the predictions in terms of doing this localized prediction, again, was done by county. So we took all the counties in Michigan, we actually looked at California and other states as well, and started to look at all these different types of data and accrue it into this. So, this would include social media data, different types of data that would come from the census that would be surprising maybe to some of you in terms of even looking at the mobility of how many people in a certain county are using different types of carpooling, how many people do they have in the house, that would be able to help with the infection rate go up quicker as that number increases. And really what it came down to is that particle swarm optimization is really nothing more than just like this computational method that would optimize a problem by trying to improve what kind of candidate solution would be given for improving that measure of quality. And so it was the ANFIS associated with this particle swarm optimization that really allowed us to go in and narrow in on this particular type of solution. And so there's other ways that you can go ahead and evaluation metrics to look at this. What we found is the best one to present to people that can kind of make the most sense. And what really got for the paper to be published in terms of the validity of it was looking at the root mean square error. And so this is basically just the standard deviation that you'd be looking at or prediction types of errors that you would have, right? So essentially these metrics would tell us how accurate our predictions are. And then what is the amount of the deviation from the actual values, right? That's what it would be covering. So, what the errors are basically the difference between the predicted values that we have and then the actual values. And so you can see by running the 14-day prediction with the smoothing algorithm over it, that we were able to go ahead and get, and this is just one of the examples of the peak that we saw within Wayne County. We were able to track very, very well, improved on other ones that had been done before what we did in terms of this, for that particular type of peak prediction, which would again allow the supply chains hopefully to be able to make sure that they can prep for that. And so we didn't have access to all of the different types of supply chain mechanisms that they would do. So we thought, okay, based on this information, what can we actually show that could be done in terms of being able to treat individuals more effectively during this particular type of pandemic? Again, a proof of concept that we were looking at. So we wanted to extend the algorithm for this disease pattern prediction to, again, assist hospitals, clinics, healthcare organizations in these specific areas for different types of coordination that they could have, right? But without having that inside aspect of where they're ordering and what their status is of it, we kind of looked at, the goal of the solution was to improve the safety of the patients while containing that spread. So can we get patients routed to ICUs that could treat them or have room to treat them based on the different types of prediction levels that we're seeing? And that's really what we set out to do in this first case. And so this particular type of model incorporated this fuzzy logic type of system, right? And so again, we kind of looked at, taking the input from hospitals, which was public information, and does the patient, if we looked at it, do they have, high blood pressure, heart, different types of problems that's associated with it? And we could kind of develop this model of saying, yes, they do, no, they don't. And we were able to use different types of information from the state with different types of approvals to be able to go ahead and use that in terms of training some of our algorithms that we were looking at. And essentially what we looked at is that, are they over the age of 60? And then based off of that, we can categorize these into different types of groups. So very sensitive group, sensitive, slightly sensitive, and then a normal group, right? And so we focused on the very sensitive group because that would be the highest risk and the highest need of different types of supply chain material that would be involved with the ICU, right? And so from that standpoint, we use this fuzzy inference system. Don't worry about if you don't know exactly what it is. But essentially what this does is it makes it possible to define these different types of rules for these conditions that we're dealing with, right? So grouping these COVID patients into the hospitals into these different categories, we could then go ahead and look at a prediction of how many people would be susceptible to be able to be routed to different locations. And again, we did this based on looking at distinct things from an ICU. So how many beds do they have available? How many ventilators do they have available? Again, different types of information that was listed publicly for us to be able to go ahead and look at. And so here's an example of the recent remaining ICU beds that we were able to go ahead and get from different types of hospitals in Michigan. Again, dealing with Wayne County, average remaining ICU beds, and we did the same thing with ventilators as we went through this. And then so we did this, we went ahead and just geographically mapped this, right? Geographic information systems with GIS. We went ahead and mapped this so we have the distance that's associated with these particular types of hospitals and per the county that they were in. And so we took this information and basically said, based on this, from each of these hospitals, come up with a scheme that would be able to go ahead and identify in terms of what the supply chain availability is, in terms of ventilators and beds, how they can go ahead and be able to make sure that those patients are admitted into hospitals that would be able to treat them and not be full. And so if we break this down into more of a focus group in this area here, this slide kind of shows a little bit more verbosity in terms of how this information is translated. So, with this current methodology, after getting this peak count that we did in the first portion for it, looking at the number of incoming patients, we could see then with Children's Hospital of Michigan, if the count is, within the parentheses that we're dealing with, we can see that it's at 25, right, for ICU beds. And so, the incoming patients then are denoted in that square brackets, which is here, is listed as 4. And then, so the value of the oval that you see right here would be essentially, how many beds are available within that hospital. And so we can kind of go through and look at this and say, expected number of patients is 4, number of patients to accommodate is 21. We have 5 patients that are going to be redirected from Detroit Receiving Hospital because, again, we have room for them in beds and in terms of ventilators. And 2 patients are redirected from Harper University Women's Hospital. 4 patients are redirected from the Cancer Center, and then we would update the availability from the Children's Hospital, set it equal to 10. Again, with the information that we had based on this, to be able to accurately depict what, in terms of statistical significance, in terms of what the actual localized prediction of the peak was per county, and then being able to go ahead and look at rerouting mechanisms that would be available if they didn't have the coordination of supply chain to be able to add the additional types of equipment or beds that would be necessary for the patients that they would be expecting. So that was the challenge and the models that we came up with that got published in IEEE, and we're continuing to work on that in more of a dashboard type of implementation, so it's more application based. And again, we can continue to improve it as we go through. The next thing that we're working at in conjunction with that is looking at taking, once we had COVID and looking at the localized disease prediction, can we go ahead and look at regional public health disease population and outbreak surveillance in terms of different types of things that, whether it's disease outbreak or pathogen surveillance within a community type of atmosphere. And that community engagement is kind of a theme that runs throughout pretty much all of the research that I do that's associated in this realm. And really what we're looking at in terms of this, and there's a few that are on the line that are associated with this project, is to really inhibit, the process of being able to utilize academic units to engage with the healthcare community in terms of adding different types of services that could assist in terms of these different types of surveillance methods that are being done. And so the state of Michigan, like many states, has gotten different types of directives from the CDC to be able to improve this process. And this is really something that we're looking at in terms of, the genomic data with the clinical data in terms of this enhanced type of surveillance and really early detection that we want to be able to look at. So if you think of humans, of course, that's fairly obvious. If we think of different types of animals, if we think of different types of soils, that could also be involved with that. Different types of testing for that is also being completed in it. And ultimately, the plan in this is again, to make sure that we can provide some kind of success story in terms of how we're doing this. Again, trying to overcome a lot of the interoperability types of issues to make sure that we have this particular type of data that is useful for individuals, for epidemiologists, for healthcare organizations, for local health departments, that they can utilize this information and we protect that security and privacy of the patient as well. So again, more of a high level view of it in terms of time, but there's a lot of different types of potential there. But again, these types of things are completely dependent on the collaboration and the different types of expertise that people have within the healthcare domain. When we looked at COVID and when we looked at even looking at pathogen surveillance aspects of it, we started to really question if we're really diagnosing and treating patients holistically, and really starting to say that, okay, only 20% of your overall health is done within the 4 clinical walls, right? That's where they're getting that information. And we have different types of directives of social determinants of health that are working on this, but there's still a lot of work to be done with this. So healthy behaviors, socioeconomic factors, physical environment, these are a big portion, obviously, that make our overall health status. And so if we really want to make sure that we can diagnose and treat the patients, then we need to make sure that we look at the patient holistically. And if we're able to go ahead and prescribe in this 20% medication for the patient, but that patient doesn't have enough money to buy the medication, if they have to choose between medication or food, then it's not really going to solve the problem either. And so what we're looking at is can we go ahead and make this into a more driven community aspect, and community in terms of the patient themselves having more opportunities in terms of what they can actually get resources for. And so this kind of started this model that we've been developing. So, the different types of health factors that we just alluded to, more specifics on what those health factors are that help determine them. And then if we look here in Upper Michigan, like many places in the state, there's a big rural health challenge that kind of goes into other elements in terms of access to care, access to different types of foods that are healthy, and other things that you can look at. So we wanted to make sure that within this local community, are the social determinants being looked at, lack of education or communication. If somebody has an 8th grade education and they're given different types of prescriptions or different types of notes from the doctors, do they understand the terminology for that? Or can we use AI to be able to substitute words that they would be able to understand? That's one of the areas that we're looking at, so that they can comprehend the different types of directions that they've been given and hopefully become more engaged with it. So ultimately, communities, whether it's urban or rural, play an important part in health and residence, and people's decisions are strongly influenced by that surrounding environment. It's just the nature of how things are. And so how can we use that to our advantage? It's really the description of this model, right? And so we wanted to look at, taking API integrated health data for users, looking at the social determinants of health, basically the AI and the digital health data, customizing health education, as I just kind of alluded to, and then also the community health resources. So being able to find a psychiatrist that would fit the different types of mental health issues or behavioral health issues that you're suffering from, which ones are the best fit for you, these types of things, to provide the resources to individuals that they can get this care, and even following on top of that, different types of telehealth processes that coincide with it. And so we can look at, virtual health societies and community-based participation research that comes out of this. But ultimately, we want to make sure that the patient has this enhanced health literacy and empowerment, right? That's research has shown that is really a significant factor in terms of helping to increase or improve an individual's health outcomes. And then increase community and personalized engagement. And then again, being able to take that information of the community's needs and then bring that back into the local community. Again, this has to have some kind of notion of feeding it back into the community. So, different types of groups, municipal groups, foundation groups, they would have that information that they can make more strategic decisions in terms of what that community needs as the biggest impact for it. So whether if it's homelessness, different types of obesity issues, diabetes, many different types of things, there's more strategy that could be based if the material or the data was presented to them in that fashion. And so we kind of looked at this and said, all right, based on this information, we know people are using smartphones, we know people are using smartwatches and getting different types of information. Of course, there's a lot of apps on there, but where can we go with different types of data that we're using for that, and how can that actually be applicable to what the healthcare organizations need. And so by that, I'm talking more about, the gaps in care that we have. So patient-generated health data, all of these different types of data that we have that right now, in many cases, I would say maybe we're not as efficient as we need to be. There's a lot of different types of data that's given to providers, but it's not really put into a mechanism that would be applicable to make sure that you can make a clinical decision very easily based on their expertise. And so usually it's things appended together, and it's kind of hard to go through and see where the important information is. And so we know that we have these gaps in care. We know that for especially chronic conditions, being able to have between visits, this is a big portion for this as well. But going through this, we can collect a lot of information. That's fantastic, right? But if that information doesn't come out to be something that's valuable and tangible in terms of leading to improvements in the patient's healthcare or their outcomes, what's the point? And that's really what we're getting at here, is that we have all of these opportunities, we have this potential, but how do we actually manage it in a way that we can make value of it? That not only the provider, the specialist, but also the patient themselves, how do they get the feedback in terms of how this is actually helping them? And so we have a lot of devices that we can use. We're looking at the architecture to put this together. Right? How do we create this architecture where we can have this particular type of bidirectional feedback and be able to use this data at all locations, right? So obviously with the health organizations, being able to have this data so this can get back to the patient in terms of community resources that they have, the behavioral health, not just the physical side of it, and then all of the different types of things that we have, right? Whether you're using your watch for Google Fit or Apple Health, or if you're using something with the car, like a sensor to be able to detect blood clots, the oxygen that you're breathing, being able to monitor different things in your heart for prevention for stroke. All of these things, again, are potential, but we need to make sure that from a big data standpoint, we're able to go ahead and actually put this in a framework that's going to be usable and have some value to it. And that's really what we're looking at, this community health type of library that we want to create for these patients to really go ahead and enhance that experience for them, to get them more engaged and to provide them more resources. And so I'm just going to kind of go over what some of my development has been. So currently I've created this platform that's this community-centric personal health record application. It's web-based, but it's also mobile-based for Android and iOS. It's called Health Shelf, and it's basically just the beginning of where I would hope a lot of different types of platforms go. And essentially, this is a platform to manage this particular type of data in a secure and private manner, and be able to utilize this from the patient to the provider to community resources to different types of care management teams, even including somebody who might be a caretaker for that individual, and really making sure that data is being updated, and again that longitudinal record is captured as well. And so the architecture for this on a more simplistic standpoint, you would have your community resources, your clinical APIs, your pharmacy, your lab results, behavioral health organizations, your physical health, and then different types of patient-generated health data as well, right? So, if you're having different types of medical devices, smartwatches, different types of things that would be included for that. And those are all running different types of OAuth 2 and different types of encryption mechanisms that are included in it as well. But essentially what you're doing is you want to create this, that you have this location, whether if it's distributed, which just means that it's in multiple places, but as the individual patient or provider would see it, it looks like it's in one location, the way that they actually are able to view it, and really be able to store this information in a way that can be beneficial for the patient and medical personnel to look at it. And really, we can start extending this into the cloud. That's where a lot of different types of healthcare organizations have already gone. A lot of the servers that they have are no longer in their organization as tangible hardware. They're now listed in the cloud, right? And so in terms of doing that, we're working with Google Cloud Healthcare API to be able to go ahead and utilize this particular type of architecture on this platform, and to be able to create this particular type of community resources. And so we've started in several different areas. I'm going to touch on just one. It's more on a behavioral health side in terms of what we're doing. But essentially what we have is we're creating this stress management and deep learning modeling. And basically what we're doing from there to just, I don't want to try to sound cool, like this is getting into things that I'm working on and people don't understand. It's very simple. We're trying to go ahead and take an application and be able to put this calculation, this model on it that can make clinical decisions without having to have it go all the way to the cloud or to a main server to be able to do it. And so we start looking at, somebody's wearing, something like an Amazon Halo, and they're able to go ahead and take their heart rate, their temperature, sleep. They're also able to go ahead and detect voice, where we can develop the model, which we have, to be able to detect if that voice is sounding stressful, if it sounds scared, these kind of things, and really look at this particular type of pilot is being done for different types of teenagers and teenagers at a certain school where we're doing this pilot, to be able to look at the detection for different things for anxiety, depression, and even suicidal ideation. So going through and training different types of models based on these factors, so features from these factors that you would look at. And it's heartbreaking to go through Reddit and see different types of content that is for suicidal ideation. But that is unfortunately the way that we need to train these models, because that's how an individual will be able to write when they're at that state. And so it's very important that we look at the potential that all of these devices have, lower memory, lower type of processing power, and how can we develop these particular type of models on these edge devices to make sure that we can give that user that information without having to bring it all the way through the cloud or to a physical server and back to them. And that's something that we're working on in order to do that. And that also increases the efficiency of giving them different types of alerts, like, hey, is everything okay? Do you need to dial 911? Or go ahead and play your favorite music list of when you're stressed versus when you're angry versus when you're sad, right? Different types of music lists for different types of moods have also shown to be very, very helpful for it. So these are some of the things that we're working on. But in order to do these type of mechanisms, that common platform, as I mentioned before, is something that's kind of key, because you can direct them to different types of locations, like maybe go to the food pantry at this location if, as we're going through this, they'd complete a stress score. And some of these would be, do you have food insecurity? Do you have problems with medications? These type of questions that they're going through and doing on a daily basis that can direct them to resources. And so this, just to give you an example, I guess a little bit more in terms of depth of where we're going with this platform is these particular types of areas. So I've mentioned, the portion with stress management, but all of these other areas as well, we're also looking to go ahead and incorporate. Another one that I mentioned on there is the independence of older adults, and this, in terms of healthy aging, is really important and a big passion for me, because I really feel that the statistics of falls in terms of what kind of change that can have for an individual who's an older adult can be really traumatic, and it can change their life quite drastically in terms of losing that independence. And so we're working on different types of things, looking at basically different types of psychological factors. And so that it's basically fear of falling and balanced confidence. And how do we improve those based on different types of sensors that we have, and being able to give individuals this particular type of steadiness score that shows that they're improving in terms of different types of things. So you can think about this on a very high level scale to say that a sensor would be able to detect if it's dark out, right? And so you could be able to say that might be a dangerous time if you're walking in the dark with no railing. You might be walking in the rain, so being able to detect perspiration, being able to have a barometer, those aspects of it are important as well. An accelerometer, that if you're walking on a really steep incline or decline, that also might be things. And so all of these things are mechanisms that are put into this model in addition to making sure that we go ahead and coincide the actual falling mechanism with the different types of sensors to more accurately be able to depict what that is. And really looking at, is this something that is, cost effective for different types of payers in terms of Medicare, Medicaid, Veterans Affairs, those kinds, to be able to give to their customers, to their members, as a preventative measure, right? Those are the things that are kind of included within this platform that we're looking at. And so that kind of gets into where we look at, different types of interoperability, and we look at patients with duplicate records, triplicate records, being able to look at models to how do we go ahead and figure that out when we have that. It's a waste of resources in terms of going through and duplicating the records. And so it's a lot of time for individuals to figure out which ones are duplicates as well. And so we start looking at different types of methods that the nation has thought of, the state of Michigan has thought of in terms of something like the common key, to be able to identify an individual all the way through, no matter where they go. And so we've spent some time in terms of looking at this as well. And we've looked at this basically from an identity management standpoint from biometrics. And I'm not clever enough to keep saying long types of words like this. So I just made it into an acronym that people could just say, like, what are you working on? And say it's umbrella. And then basically just unique medical biometric recognition and enforcement of legitimate and large scale authentication, which essentially just means like, hey, I want to be able to easily tell who I am, or for my physician to be able to access my records based on biometrics, so they don't have to remember passwords and any other thing that makes it challenging or difficult. And so this was kind of the notion to do it. I actually got this idea from my son, who has different types of medical problems. And like many parents, we would go to different locations, the Mayo Clinic, University of Michigan, Marshfield, in addition to the local ones as well. And every time we would have to bring this huge binder of information because they might have information inputted wrong, the medications wrong. And so it was a challenge. And I kind of thought that there could be a better way in terms of doing this. And that's what kind of prompted this research project, which essentially looked at identifying, again, both the patient and the medical personnel that's using it via these touchless biometrics, and then making sure that you have this digital health exchange between unlike systems. So if you have McKesson and ECW, and they each have their different ways that they identify who that patient is, can we make sure that we can make sure that patient is the same throughout those two systems, and of course scale it globally? And so we started looking at this, can we help with the rising cost of healthcare, and then make sure that this is going to be hardware agnostic. So you don't have to buy this specific phone to be able to do it, or this specific camera from your computer to be able to do it. And it had to ensure that you had security and authorization within a large scale. And essentially what this did was this looked at creating this unique health identifier. And it did it first by looking at the finger. And again, I'm giving you a proof of concept and a model that's being developed. This could be done with retina scan. This could be done with anything else as well. But I chose to do it with the fingerprint, and then use facial recognition as a secondary. So the fingerprint itself, the reason why it says one to many is because it is a model that develops a unique type of algorithm from your unique fingerprint. And it's not just one fingerprint. It can be multiple fingerprints, right? So you could have it do 4 at a time, or you could do 2 hands. And as you obviously use more fingers, it will increase the accuracy of the particular type of UHID. And essentially what this does is this comes back and looks at the facial recognition from what you have from the hospital that you were at, and matches that facial recognition as a secondary to say, yep, this is definitely Guy Hembroff, or this is definitely Dr. So-and-so, right? Who's trying to access his records. And so what we did was we looked at this in terms of, do we want to do touch or touchless? And it's like, there's a lot of different hygienic issues and sterilization issues that we have. I'm sure with COVID, everyone is on high alert in terms of this as well. So there's, again, potential fraudulent use from being able to touch something. There's many ways on YouTube that you could look at how you go ahead and make a gelatin type of finger based on what kind of print was done on the sensor. And then you have a lot of uneven. So if you think of something with Parkinson's disease or other things, it's very hard to make sure that you have an even one when you put your thumb or your finger on many different ways. Maybe if you've accessed your phone, you probably have dealt with that at some notion. So with the advancements that we had in cameras, we were able to look at this and say, you know what, can we just do this by a touchless mechanism? If there is some kind of tremors, can we go ahead and normalize the data in terms of the fingerprint so that it won't affect the actual capture of it? And that's what we did. We looked at web cameras, laptops, smartphones, and we basically looked at this information and developed an algorithm based off of certain types of masking and cropping techniques that we were using, and essentially came down to looking at this reliable method of this fingerprint triangulation. And there's a lot of things that go into this algorithm, but essentially, if you look at it and you do triangulation, whether you have a tented arch or different multiple arches or different types of swirl patterns, all of these things are basically applicable to this different type of triangulation. And the great thing about the triangulation aspect of it is that it's really invariant to a lot of different types of things, right? So it's immunity against noise and distortion. We've already looked at that. And really the angles of the triangles that we're looking at are invariant to translation, rotation, scale. So it doesn't matter what, how close it is or how much they actually twist it. We'll be able to go ahead and do that based on the mechanism that we're using. And so we did this. This would come up with a unique identifier. And again, that identifier would be increased as you added more fingers to it. So it's not just one finger specific. But again, we did it on one and we had 99.99999 accuracy in terms of what we were looking at. And we did this on scaling for 7 million patients that we did this for in terms of using different types of patient records in Cynthia. There's papers on this as well. So we did that. You found the record. Once you found the record, it brings it back to doing facial recognition. So the phone, the camera of the laptop would do facial recognition. And again, if it was your provider, it would give them the information that they were supposed to see and not just all information. And so there's information on the different types of algorithms that we incorporated for this. There wasn't a whole lot of development because when we looked at this, Fisher-face algorithms were so highly developed. I had to do little types of development to be able to have it coincide with the application that I was using. So most of the descriptive portion of the development of the biometric was added to the fingerprint and not as much with the facial recognition. But once it confirms that individual, then it releases the portion that individual has access to. So obviously, if you're the patient, it gives you everything. If you're the radiologist, maybe it doesn't give you everything. Whatever those policies are would be enforced for when the individual authorizes it. So no passwords and things like that. It uses FHIR, which I'm banking that a lot of people in this group know what FHIR is. And other different types of RESTful types of things. So it's lightweight and it does different types of cross mapping. I think that's the main thing that I wanted to get through with this, is that again, if you have an ECW and you have an EPIC system, those particular types of patient identifiers can be cross matched into the patient identifier that you have that would be your global identifier. The patient, the individual, nobody actually knows what the unique health identifier is. It is encrypted upon its inception and encrypted every time that it's used. So you never know what that actual number is, but that number is the same for the individual as they go ahead and utilize the system. So yeah, it uses FHIR in terms of the resources, and then it uses a federated type of approach in terms of, for the record locator service. So you don't have to store all of the records for this longitudinal type of record for a patient. Essentially, you have your local, your regional, your state, and your federal. And based on your particular unique health identifier, it will use that record locator system to first identify who that individual is. And once that individual has been authenticated and authorized on both of the biometrics, it then will go ahead and acquire the different types of information, that longitudinal record that the individual has access to. Right? That's a key component to it. So that's why you see all of these different types of policy enforcement points, policy decision points, and this umbrella that shows you where these are located for it. So essentially, the sum of this is that currently there's no scalable and accurate national patient identifier or global patient identifier that's out there. That's done from a biometric standpoint. And so this was one area that we wanted to look at and develop, and where we see things going. Again, Umbrella is an end-to-end conceptual model to be able to do this, and it's based on the primary, the fingerprint, and the secondaries being facial recognition, and looking at a lot of the interoperability mechanisms that go between were analyzed as we kind of went through this. And so basically, I know in terms of time too, I kind of wanted to just sum up that, through looking at population health through pandemics and different types of ways that we can go ahead and model out in terms of community to make sure that our communities are improving in terms of their healthcare outcomes, but also getting the resources to be able to do that. And really the nuances that they have in terms of education and location, different types of access, that we have the potential to create these particular types of models and mechanisms and technology to be able to do this. But of course, there's a lot of other elements too that we need to make sure in terms of interoperability challenges and security and privacy challenges as well. And so what I wanted to do is just kind of give you an idea of why this collaboration is so important. Hopefully you were able to see through the different types of work that I do that I would not be able to complete those projects or have those in further development without having expertise from the healthcare community, and whether if it's from IT or it's from a medical physician, all the way through has been instrumental for me to be able to do the work that I do, that I'm so passionate about. And so if there's any type of theme or ending on this, is just that really it's what we can imagine and what we want to be able to do, whether if it's data science techniques or different types of methods of medicine. It takes really a group to be able to make these things go large scale. And I think that's what HIMSS has been so instrumental in terms of getting people together and showing the different types of possibilities and potential to do that. And so I just wanted to show you a very small part of what I do to maybe give a little reflection on just on how much I've appreciated that interdisciplinary type of nature and how it's helped the research that I do here at Michigan Tech. And I'll leave it with that for questions.
Thank you so much, Dr. Hembroff. If anyone has questions, if you want to put them in the chat or raise your hand, I will go through those. This session was also recorded and will be viewable on the HIMSS website once it's uploaded. All right, I see that Lee has a question. Do you want to go ahead, Lee?
Hey guys, Lee Marana here, the HIMSS Michigan president. Thanks for joining today, appreciate it. Anybody that's going to HIMSS 22, I believe Dr. Hembroff's going to make it there. And
yep, I'm excited. My first HIMSS conference, yeah.
Yeah, so we're really excited to have him join us there as well. So he should be at the Michigan reception as well. And impressive work. Appreciate your dedication, to the health IT community. And I just want to say thank you very much for presenting today as well. I think Dan and Teresa have a couple questions in the chat.
Sure. So what do you think would be the catalyst to get providers to engage? That's a good question. I think the biggest thing that I would see as the catalyst is keeping the workflow consistent. I think once you deviate from the workflow and providers have to deal with yet another piece of software and another screen, it becomes really challenging in their busy day to be able to go ahead and do that. I think at least that the physicians that I've worked with, they've been terrific in terms of the support for it, but they've also been very honest in terms of what the limitations can be. And I think that's important for researchers or people who are developing to not just kind of, have this idea, develop it, and just expect people to go ahead and use it. It needs to show value to the people who are using it every day. And I'll give you a really quick example. Even going ahead and changing an icon can be really disruptive to somebody who uses it multiple times a day and is going ahead and has a limited time to be able to do it. Just something like that can throw off the trust factor for it, or even the intention to use it and the comfort level with it. So it takes both sides to do that. And I would say that as much as, from our side, we're very anxious for physicians and medical staff, nurses, physical therapists, all of them to be able to utilize it. There's a lot of onus on us to make sure that it's in a methodology or process that they can really benefit from. And I think that's often understated and not done enough in terms of development before it's actually released to the medical field. Teresa, is Health Shelf able to be used now? No, not quite yet. It's being piloted now. And based on that particular type of feedback, we'll be moving it into commercialization, hopefully within the next year, year and a half. Any other questions?
Don't see any more in the chat. If anybody wants to raise their hand as well, feel free. Come off mute if you want to ask a question.
And likewise, too, if my contact information is there, as I said before, I'm really excited about working with individuals and learning from other individuals. So if you want to go ahead and follow up later, too, that's fine.
Great. Thank you so much, Dr. Hembroff. This was an amazing presentation. It's always so delightful to hear you speak. I think we'll go ahead and end there. If anyone wants to follow up with questions, please feel free. You can send them to Dr. Hembroff herself or to me, and I can pass those on. Thank you all so much, and thank you so very much, Dr. Hembroff.
Yeah, thanks for having me. I enjoyed it. I appreciate the opportunity. Goodbye, everyone.
Thank you. Bye.